Hi, my name is Hayley Sturgis, and for EHR 523, my case study is breast cancer. Deborah Rosenthorn is a 76-year-old female who detected a lump in her right breast in mid-2016. In November, Deborah had noticed that the mass had got larger and went to her GP for ultrasound-guided core needle biopsy, and it was revealed the presence of breast cancer. After CT, bone scans and blood tests, it was revealed a T2N3MO invasive ductal carcinoma with estrogen positive, progesterone positive, but negative to HER2 receptor. The detected lesion was 23 times 22 times 18 millimeters in size, and there was extensive lymph node invasion, with no evidence of bone metastatic disease. Deborah received a right mastectomy and axillary node clearance, and also got her left breast removed due to precaution, and lymph node clearance as well. This was in January 2017. Deborah started chemotherapy in March with dose-dense AC through IV, along with weekly paclitaxel. Deborah was referred to a radiation oncologist for a second opinion, and she received radiotherapy treatment to high-risk areas. Blood tests, CT and bone scans revealed that Deborah had a positive effect to the treatment and that there was no disease remaining. Deborah continued with hormone therapy, in particular Armadex, and this is continued for 5 years to help with the prevention of recurrence of breast cancer. Deborah will also meet with her medical oncologist every 6 months for review. Deborah did experience some side effects to her treatment. So after her first cycle of chemotherapy, Deborah experienced persistent nausea, vomiting, decreased platelets and neutrophils, bone pain and urinary incontinence. She was also admitted to the emergency department with pneumonia. So the decision to stop the dose-dense AC was made, and just to continue with the paclitaxel. Deborah experienced some minor difficulties and developed a seroma on her right chest wall. There are some common side effects of hormone replacement therapy as well, and it can include fatigue, osteoporosis, and the risk of secondary disease. Deborah's non-cancer related medical history includes osteoporosis, hypothyroidism, a total left hip replacement, osteoarthritis of the left hip and both knees, hypotension, and GORD disease, along with an elevated BMI in the obese category, an elevated waist to hip ratio in the high category, and these two factors alone are going to increase Deborah's risk of a secondary disease. Currently, Deborah's blood chemistry values are within normal levels, though without a lifestyle intervention, we can assume that particularly cholesterol and blood glucose levels will rise. So major short-term health concerns for Deborah include restrictions in activities of daily living, acute pain, cognitive changes, and the risk of falling. Major long-term health concerns for Deborah include the cancer reoccurring, secondary disease, the risk of falling, a decline in mobility and or functional status, the long-term side effects of cancer treatment, chronic pain, emotional and psychological issues, the risk of secondary cancers, body image issues, financial issues, increased body mass and reduction of muscle mass, bowel dysfunctions, and interpersonal problems such as stress and adjustment difficulties. So there are a magnitude of benefits of exercise for Deborah. So exercise can really help manage the risk of secondary disease. It can help increase bone mineral density, which is going to help with reducing falls and therefore the risk of fractures. It can help improve cognitive functioning and mood, can help with weight reduction, and this is also going to help with her osteoarthritis and osteoporosis, reduce lymphedema, help manage the side effects of medications, improvements in psychosocial functioning and improving health-related quality of life, increasing the ease of activities of daily living, and helping to manage the acute and chronic effects of chemotherapy. Exercise can also help reduce the risk of cancer-specific mortality and cancer recurrence and all-cause mortality. It's also been evident that resistance exercise combined with impact exercise can increase bone mineral density. And exercise has also been demonstrated to have significant effects of cancer-related fatigue. I've decided to refer Deborah to a dietitian and physiotherapist. and who are both allied health professionals who exercise physiologists work alongside frequently. A dietitian can help Deborah by helping her with client education regarding food and nutrition choices. A dietitian can help her lower her BMI along with waist to hip ratio and total body weight, help prevent the increase of cholesterol and blood sugar levels, and provide nutritional recommendations to manage her hypothyroidism, osteoporosis, and osteoarthritis. A physiotherapist can help Deborah through the means of lymphedema prevention, help to improve shoulder range of motion and to assist with activities of daily living, decrease pain and improve function related to osteoarthritis and osteoporosis, increase her mobility and functional independence, along with client education. So the risk of exercise for Deborah is identified on this slide. It's essential to note that all cancer clients are considered as high risk and that it is essential to be obtaining a medical clearance prior to exercise. So the first risk identified for Deborah is hypotension. The second, the risk of developing lymphedema. The increased risk of a cardiopulmonary event. Osteoporosis, which may increase fracture risk. The risk of cancer-related fatigue. Medications as a risk to exercise, and the risk of developing peripheral neuropathy. So in the next few slides, I've identified the largest risks to Deborah that I perceive and strategies on how to combat those. So hypertension as a risk to exercise, it is essential to be monitoring Deborah's heart rate and blood pressure throughout her exercise sessions, but particularly pre and post, and just to let her have adequate rest breaks in between sets when needed. The next risk is cancer-related fatigue as a risk to exercise. So Deborah's exercise should always be tailored to her individual needs. Programs should be periodized and they should have a slow progression of intensity in volume. So it is essential to be monitoring the client. So this can be done through asking Deborah's rate of perceived exertion. The next risk is falling as a risk to exercise. So it's essential to be choosing appropriate exercises for Deborah, providing regressions when needed, decreasing the intensity and volume when needed, and having safety precautions in place such as the chair or Deborah's husband or myself as the exercise physiologist there for support. In summary, it is essential to be monitoring Deborah throughout her session through RPE and also assessing her blood pressure, heart rate and pulse oximetry when needed, but particularly pre and post exercise session. The 5 physical assessment tests I've selected for Deborah are a 6-minute walk test, which is an assessment of exercise capacity, an important predictor of mortality for cardiovascular disease and pulmonary disease. So Deborah's expected results for a 6-meter walk test is 327 meters. So anything under 424 for Deborah's age is classified as very poor. So this is going to put Deborah into the 10th percentile. The next test is a Berg balance test. So this is an assessment of balance, particularly in the elderly, and it's great to help assess the risk of falling. So Deborah scored 42 points out of a potential 56. So for normative values based off Deborah's age, she should be scoring around 53.9. Despite this, she is independent, so not requiring a walking aid, but it does tell us that she is at risk of falling. The next test is a range of motion test of both shoulders, and I've selected this test because after breast cancer surgery, range of motion of the shoulders are often restricted, and range of motion also decreases with the natural aging process as well. So the 2 biggest values to look on this table is abduction and flexion. So these are significantly reduced in Deborah in comparison to normative values. The next test is a 30-second sit to stand, and this is an assessment of lower limb strength and functional capacity. So Deborah scored 8 repetitions, and on average for her age is 10 to 15 repetitions. The next test for Deborah is a 30-second arm curl, so a bicep test, and this is an assessment of upper body strength. So the normative values are based off her dominant hands, but I have put in her left hand as well for a comparative value. So Deborah did score 10 reps on her dominant hand, 9 reps on her non-dominant hand, and the normative values for this is between 11 and 17 reps. Therefore, based off those physical assessment tests and their results, The three major priorities for Deborah regarding her exercise should be: number 1, to increase her aerobic capacity; number 2, increase her balance; and number 3, increase shoulder range of motion. Based off these priorities, I've created 3 goals. So her first goal is to increase her aerobic capacity, and long term we want to see this goal achieved by improvements in her 6-meter walk test, so particularly improving from 327 meters to 425 meters. And this can help be achieved by completing a short-term goal, which will be to complete 2 walks per week with her husband Paul between 10 and 20 minutes, and I want the intensity to be light, so still being able to maintain a conversation with Paul. The next goal is to increase her balance, and long term this will be achieved through the Berg balance test, and we want to try and get her from 42 points to 46. And based off normative data, this would tell us that Deborah would not be at an increased risk of falling anymore after her 8-week program, which would be great. And this can help be achieved by her short-term goal, which is to perform a Romberg exercise 3 times per week and just holding this for 30 seconds. And her last goal is to increase her shoulder range of motion. So this is going to be assessed long term by a shoulder range of motion test, and we really want to see improvements, particularly in flexion and abduction, and these were the most restricted values. So short term, this is going to her short term is going to be to perform a shoulder wing exercise 3 times per day, but 2 times per week, and we're just going to do 10 repetitions of this exercise. Deborah's 8-week exercise program is split into 2 aerobic exercise sessions, 2 resistance sessions, and 1 mixed session. Deborah also has additional walking on the weekends to help achieve recommended guidelines throughout her program. Volume throughout her 8-week program is expressed through MET, so metabolic equivalents, along with sets times reps times weight. The intensity of her program is calculated by a percentage of heart rate reserve, and for the purpose of this I've created an arbitrary resting heart rate of 68 beats per minute for Deborah. For resistance-based exercise sessions, the intensity will be expressed as percentage of 1 rep max. Now it's important to note that within the 8-week program, it doesn't have the sets times reps times weight and percentage of 1 rep max in the program. To do this, we would need to do some additional exercise testing with an exercise physiologist prior to the program starting. And instead of doing percentage of 1 rep max with Deborah, I would like to perform a 10 rep max test, as this would be a safer option for Deborah, and then using an equation to figure out 1 rep max. Deborah's program is split into 2 mesocycles. So the goal of the first mesocycle is to increase her compliance to exercise and just slowly build upon intensity and volume. As Deborah's been sedentary for so long, I really just want to encourage adherence and participation in the first 4 weeks. In her second mesocycle, the goal is going to be building upon the skills learned in the first mesocycle and starting to achieve these long-term goals, so increasing her exercise capacity, her balance, and her shoulder range of motion. For rest breaks in Deborah's program, I'd like a minimum of 60 seconds per break, but if her RPE is quite high, then more time can be provided if needed, particularly if she is feeling any signs or symptoms of orthostatic hypertension, then certainly more rest break will be needed. Progression has been included in Deborah's 8-week program in a various amount of ways. So there's been an increase in sets, reps, and weight over the 8-week period, along with slight increases in volume and intensity. The other thing is the increase in task complexity. So for example, with Deborah's balance exercises, they do become more demanding throughout the 8 weeks, and this has been done by adding dual tasks, getting Deborah to close her eyes, and increasing the duration of the exercises as well. So on the following slides, I do have Deborah's 8-week program. So this is week 1, week 2, week 3, week 4, week 5, week 6, 7, and week 8. So the expected results of Deborah's program would to increase her overall strength and conditioning, and we would also really like to see improvements in her exercise capacity, shoulder range of motion, and improvements in her balance as well. Thank you for listening to my slideshow. On the following slides, I do have my reference list.